Then we move into the primary survey. So we found that we have maybe a single patient, or we have our patient. Even if there's more than one patient, we have our patient. And the goal here of the primary survey is to find the life threats. So these are threats to the ABCs. If a life threat is present, we want to stop and correct it immediately. If life threats can't be corrected, then basically we do what we can and get them to somebody who can fix it. Support the ABCs and transport your patient. With critical trauma, it may be that you never get past your primary survey. Now, remember that a primary survey is going to include a quick head to toe. So you kind of your quick head to toe here. Quick head to toe. But that's really just to look for life threats. So the first step here, after we've identified level of consciousness, is airway with C-spine control. At this point, we don't need a C-collar just yet. We are going to have a person hold the patient's neck in place. So you want to return the head to neutral position, which is basically think about how you would lay on your back. Your head isn't going to be straight up and down. It's probably going to be off to one side or the other. So neutral position is think about that anatomic guy from the very beginning of class. It's facing forward. So if the guy is laying flat on his back on the ground, you're going to actually turn the head up straight. And that's called a neutral position. If resistance is met, you want to hold in place. If you have resistance, it could be that there's some sort of injury and we don't want to further injure the patient. You can stabilize at this point without traction. That means you basically just hold it. You don't pull on the head, so don't pull. Don't push or anything else like that. But without traction means you don't pull on their head. While we're doing this, we're going to be assessing their airways. So and one of the first steps we do is we move their head up to neutral, and then we're going to listen for noise. Basically, is their air moving? And if so, is it clear? So with the airway, remember, assess, look, listen, and feel. So assess for air actually moving through their airway and listen for sounds. If your patient has a decreased level of consciousness, if they have head trauma, facial trauma, neck trauma, or upper chest trauma, you want to really be on top of the airway. Just keep reassessing it repeatedly and do a good job of clearing it out and maintaining it if you do have anything wrong. Then we move on to breathing. Is air moving? So is the chest moving up and down? And if so, is it moving adequately? Do we have a good rate and a good depth? Is oxygen getting into the blood? This is something that, we can usually use the pulse ox to assess, but in a critical trauma patient, we're really going to kind of, look at the lips and see, are they pale, are they blue, or are they pink? And that's really part of circulation as well. If the patient has a decreased level of consciousness, if you think they may be in shock or they may have a severe hemorrhage, or you obviously can clearly see a severe hemorrhage, and this really could be internal or external. So if you're concerned they have internal hemorrhage, like an abdominal bleed, and you can't actually see the bleeding, then you want to be sure to oxygenate immediately. If the patient is having shortness of breath or appears to be in respiratory distress, then put your patient on oxygen. And at this point, it's okay to use oxygen via non-rebreather at 15 liters per minute. Oops. So if you have any of these, then go ahead and just put your patient on a bunch of oxygen. You can always back it off later if you have time and the patient's stable enough for that. Consider assisting ventilations if respirations are less than 12 or greater than 24, or if the tidal volume is decreased or you have significant respiratory effort. This says consider. You need to strongly consider, but remember that sometimes patients after car accidents may be really upset, and it may be normal for them to breathe fast. The key here is assessing, do they need help breathing? Are they getting the oxygen into their blood? Is their breathing effective? And are they going to be able to sustain it? So somebody may be breathing 36 times a minute, and that's okay for now, but see how long you can breathe for 36 times a minute. You may need to help breathing to help kind of slow their rate down a little bit so that they can get a good volume in. If you're looking and you're trying to assess, I can't tell if they're breathing, you know they're not awake, they're unconscious. If you don't think they're adequate, or if you can't tell, then they're probably not adequate. And if you're wondering, I wonder if I should bag this patient. Maybe, well, let me just take a little bit longer to think about it. Well, okay, at that point you probably should be bagging your patient. If respirations are compromised, expose the chest, especially in trauma, because you never know what you're going to get. It could be that you find a hole in the chest from a gunshot or a knife. So inspect the front and the back, and you're going to look, and I'm also going to say look in the armpits and the side. So look in axilla and around the side of chest. And the reason for this is because that's a good place for holes to hide. We don't always think I need to look in the armpits, but bullet holes and stab wounds, it's awkward to get them there, but if somebody's in the middle of a fight, they may not notice that they've been stabbed or shot there. You want to listen, so auscultate both the front and the back, and then you're going to palpate, feel. And with this, you're going to try and basically have the patient breathe, take a deep breath while you're feeling, and try and feel all the ribs the best you can. So feel all ribs. And then feel a breath. And you want to make sure when you're feeling somebody breathe that you don't feel any crepitus and that their chest is moving up and down equally.